questions around 5:30. By the end of our presentation, we hope that you have a better understanding of suicide prevention. You know how to assess suicide risk and protective factors. You know how to use best practice interventions to ensure safety, including lethal means safety, which I'll cover extensively when I present after Dr. Shah, and better understand how to follow up to ensure continuity of care. So Siyan Clinical is giving this presentation with no conflict of interest, and the event is not sponsored by any commercial entities. We are offering 2 CME and CE credits through our partners, Fresno Madera Medical Society and Spiritual Competency, to those who qualify and that attend the entire presentation without turning their cameras off. So please complete the evaluation at the end. And in order for you to get those credits, we need you to take a moment to sign in. So if you could type your name, your credentials, your email, and your license number in the chat box. We're going to start to take note of those so we can send you the evaluation at the end of the program. So while you're writing your name and your email, your credentials, and your license number, I'm going to introduce our first speaker. His name is Dr. Anish Shah. Dr. Shah opened Siyan Clinical Corporation in 2012 with a passion for helping our community and has continued to do so over the years through clinical research, education, and ongoing support through the wildfires. He kept his business open during the COVID-19 pandemic, enabling us to serve people suffering due to isolation from shelter in place. He has extensive experience in the field, including serving as the medical director at Napa State Hospital and as a general psychiatrist for Lake County Mental Health, Kaiser, and Sonoma County Mental Health. So without further ado, here is Dr. Shah. Please enjoy.
Thank you, Aubrey, for the introduction, and welcome everyone. So my focus of today's presentation is to talk about biological treatment of high-risk patient and the role of primary care physician and mental health professional in evaluation and treatment of suicide and suicide ideations. And in today's presentation, we will explore topics such as biological, socioeconomic, and circumstantial factor that increases the risk of suicide ideation and behavior. We'll also look at the prevalence of suicide in our national and global scales, the relationship between psychiatric illness and suicide ideations and behavior, and how they both interrelate with each other, examine how primary care physician can prevent suicide occurrence. And then there is always a controversy about biological risk that is associated with antidepressants in children and young adults, and we will touch base on that topic today. And we learned about methods to help manage and care for suicidal patients. First, before we start our presentation, I would like us all to be familiar with some of the terminology around suicide. From the basic terminology. So first is suicide ideations. A patient who has thoughts or plans to kill himself, suicide threat or gestures, when somebody is verbalizing actions that can cause others to believe that an individual wants to kill themselves. That's what we call a suicidal threat or gestures. The third terminology that we commonly use is non-suicidal self-injurious thoughts and behavior. That means that when there is deliberate injury to one's body tissues without the intent to die, and that by definition is non-suicidal self-injurious thoughts and behavior. And last is suicide attempt, where self-injury is with the intent to kill oneself, and usually it's non-fatal. Now, when we look at prevalence of suicide globally, then more than 45,000 people in United States and 800,000 people worldwide die of suicide each year, which is quite a bit of a death, the death that can be prevented easily with evaluation and treatment. So that's, I guess, it is an astonishing number in my opinion. Globally, suicide occurs in 12 out of every 100,000 individual, making it the 14th leading cause of death. Again, it's significant because that's something can be prevented with appropriate interventions. In the United States, suicide occurs at least 15 per 100,000 individuals, making suicide 10th leading cause of death, so suicide is in the top 10 in terms of etiology. For every suicide that occurs, there are estimated 10 to 40 non-fatal suicide attempts. One of every 100 people who survive a suicide attempt will die within the following year. Patients who attempt suicides are approximately 100 times more likely than the general populations to die by suicide. Patients with mental health issues, including schizophrenia, major depressive disorder, and bipolar disorder, are at highest risk. So patients with those diagnoses, we should watch out for the suicide risk to be more prominent. Now, psychiatric illness, more than 90% of the patients who attempt and 95% who die by suicide have been diagnosed with some form of psychiatric disorder. So you can imagine people who commit suicide, the comorbid psychiatric illnesses is significant, almost prevailing in all of those cases. The most common disorder, like I explained, is bipolar disorder, depression, substance abuse, schizophrenia, personality disorder, also plays a part, mostly with some parasuicidal behavior that I call anxiety disorder, PTSD, and delirium. So our elderlies with fluctuating cognitions are also at high risk of suicide. Now, I want to touch base about what COVID-19 has done in last 1 year. Obviously, Kaiser did a study. When can you come in here? Somehow I don't see my slide. Okay, now it's fine. Okay. So, when the Kaiser Foundation did a study in April 2020, they found social isolation of COVID-19 that took a drastic toll in mental health in Americans. And that study suggested that 45% of the adults who surveyed reported that the pandemic had taken a toll in mental health. We at Siyan Clinical were fortunate to get a grant through SAMHSA, and we developed a program under our project director, Aubrey's leadership to evaluate and treat patients who have suicidal ideations. And under that grant, we did a study using EPIL tool inventory to see what the impact of pandemic is on patients who have pre-existing mental health issue. There was a very little research done to address mental health tolls for Americans who were already burdened with mental illness during the pandemic. If patients with mental illness and substance abuse issues are already at high risk of suicidal ideation and behavior, then how the pandemic of COVID-19 would impact those populations. And that is what we wanted to study using EPIL tool. So in our study, we did 245 adults that we recruited from our mental health clinic who already had a pre-existing mental health disorders. We surveyed them using EPIL tool. Then we also categorized various demographic factors and also psychiatric diagnosis that plays into. And then we and the participants were male, mostly 18 and above, and we surveyed up to 75 was a cutoff date for age. Our survey results pointed out that genderqueer, transgender, and other non-conforming individuals reported the highest number of negative indicators than any other population. So they were vulnerable populations. And adults with children under the age of 18 reported more positive and negative indicators. So there were a mixed bag feelings in our tools in terms of what we saw in patients with less than 18-year-old. Participants aged 75 and older were shown to be at least affected population, followed closely by 65 and 75 years of age. So least affected populations were geriatric populations in our survey. And we can conclude that population with pre-existing mental illness who have children and are at younger age groups are at higher risk for suffering negative effect from the social isolation of COVID-19. So younger, the COVID-19, to summarize, COVID-19 had prominent impact on younger subpopulations and who have children, and that's what we found. We are publishing this result at this time, and our call of action out of doing all this work is that there is a need for healthcare professionals to use foundation research to better treat patients during this pandemic. It can assist in prevention, care, and treatment of mental health patients, and may be a critical tool to help mental health practitioners understand these patients. Patients who suffer from chronic debilitating health condition illness are at increased risk for suicide. For example, someone who have asthma, cancer, COPD, coronary artery disease, diabetes, spinal cord disorders, stroke victims, post-surgical patients, and other chronic and terminal illnesses increases somebody's risk for suicide. Chronic pain sufferers have about 15% chances of dying by suicide and 20% chance of suffering from suicidal ideation in lifetime. So someone with chronic pain, we have to take them seriously when they endorse suicidal thoughts, which may be particularly of an interest for primary care physician when see their patients with chronic pain. One study found that 9% of the participants who died by suicide were chronic pain sufferers, although research estimate that numbers to be much higher. Back pain, cancer, and arthritis were the most associated elements when it comes to chronic pain and suicide. Social and cultural risk factors. Sexual minorities face the highest risk for suicide. Study shows that sexual minorities are 2 to 3 times more likely to attempt suicide each year. Sexual minorities are 4 times more likely to die by suicide than the general population. Additional risk factors such as sex, males are significantly more likely than females to die by suicide. The global suicide rate is 15 out of 100,000 for male population. This contrasts with the 8 in 100,000 females who die by suicide. Single, unmarried individuals are more likely to have suicidal ideation and suffer from death by suicide. There are circumstantial factors that always play into suicide, and we should be mindful of those. One is marital separation and divorce, loss of employment, sexual identity crisis, abusive relationship, school and social issues, chronic isolations, loss of loved one, childhood abuse, and unskilled laborers. When we have a patient with suicidal ideation, the 4 elements that is important as an initial interventions, one is to stabilize them, reduction for immediate risk for harm, develop a treatment plan, manage the underlying factors, if it's psychiatric disorder or medical condition, and then have subsequent close monitor and follow-up appointments. Those are the 5 key points when you see patients with suicidal ideations. Now, I would like to focus some on pharmacotherapy and some of the controversy of pharmacotherapy in treatment for suicide. And there's a controversial topic about in 2007 when FDA issued a warning for children, teens, and young adults, that they may be higher risk for antidepressant. And let's examine that aspect today. So when this warning came, I think this warning came after a paroxetine trial which showed some increase in suicidal ideation in children, teens, and young adults. But when there were subsequent studies done, there were no difference in suicidality among antidepressant classes. And that includes SSRI, SNRI, MAOI inhibitor, tricyclic antidepressants, etc. But there is a high risk of suicide in children and teens and young adults who are taking antidepressant. At least that inference we can make from the paroxetine trial. So there is a need for increased monitoring and follow-up when you are prescribing antidepressant to younger adults. So that is obviously a conclusion that we can make and safely include into our practice when it comes to use of antidepressant in young adults. Now, one other aspect that we must also look at closely about what it does for untreated mental health illness. If you don't treat it with medication, what would that risk be like? And clearly the risk is much higher when you have somebody with severe mental illness, especially clinical depression, when it gets untreated with SSRI. The other aspect to also take into consideration that the first month after you start antidepressant, there is some propensity to increase in risk. And after that the risk goes down in young adults. So the parents and families should be monitoring their young kids, their teens, their children, their loved ones for first month, along with primary care physicians, mental health professionals, psychiatrists, when they start prescribing antidepressant. One other reassuring study was the fluoxetine trial, which shows some positive results in young adults, meaning that after the first month was passed, the symptoms improved on a 12-week period. So if you try antidepressant for a longer period of time, then there is deep in depression, and then long-term risk of suicide goes down. So that is what we get out of this data that we have. However, there is no reliable data, and there's always a controversy about placebo effect of antidepressant. The other aspect, when you look at clinical trials utilizing SSRI and also depression, then one thing which is missing in our approach right now is we recruit patients for clinical trial who are not at significant high risk of antidepressants. So we don't have a very clear data about what antidepressants do to somebody who has a high suicide risk, because most clinical trial recruit patients who have mild to moderate suicide risk. So that is a missing gap that we have right now, and some days that needs to be addressed to really have a good understanding about what antidepressant does to suicide risk in younger adults and in adults. The other part with paroxetine trial, another paroxetine trial that I want to point out, that there were significant symptom improved in depression patients. So a recent study of 231 participants, they were decided into 3 groups. One was paroxetine, cognitive behavioral therapy, and placebo response. And they tried to see the result. And as we all know, the results were conclusive along the line of all other trial data that we have seen. When you use psychotherapy in conjunction with biological treatment, like paroxetine, SSRI, any other type of treatment, then the results are the best. And that's what the paroxetine trial also showed up. So someone with moderate to severe depression with suicidal ideation, it is always great to have an optimum treatment plan that involves biological treatment along with psychotherapy. The other part I wanted to point out is about lithium studies. There was a clinical trial. There were 48 clinical trials that were examined using 6,674 participants, and they did a pooled analysis. And in that, they showed that lithium is effective more than placebo in reducing suicide risk. So lithium is a lifesaver, and we use very, very frequently in biological psychiatry. And I would encourage primary care physician to use lithium as an augmenter when it comes to treating depression with somebody with suicidal ideations. Um, Lithium is also most effective in reducing the risk of suicide in bipolar depression along with unipolar depression. And lithium also prevents recurrence of mood swings. It reduces agitation, impulsivity. So when they compare lithium with other drugs like amitriptyline, carbamazepine, lamotrigine, lithium obviously had a superior data. When you use lithium for treatment modalities, you also don't need to go on a higher dose. You can use those in the range of 450 to 600 milligram with the blood level of 0.5 to 0.6. So lithium is a good augmenter also for someone with chronic parasuicidal thoughts. Now, if you compare SSRI and SNRI, SSRI are typically used to treat high-risk suicidal patients. However, if you have a choice, if you want to pick an option, with somebody with chronic overdose tendency, with suicide risk, then you should try avoiding tricyclic antidepressant, monoamine oxidase inhibitors, SNRI like venlafaxine and Cymbalta, because taking those medications along with the lithium in a very high dose may prove to be lethal. So that is one clinical consideration that we can draw out of the multiple trials that have done. Try to use SSRI if somebody has higher risk for suicide. Now, this is another interesting new research that is emerging, and that is about use of ketamine and then the newer molecule S-ketamine which is a nasal treatment that has come into market, I think, close to about a couple of years. The ketamine is a medication that can help change medicine if proper research is conducted before it is effective in an incredibly fast amount of time. This medication helps prevent with severe major depressive disorder. So one of the randomized trials that revealed that an infusion of ketamine, so ketamine started with the infusion and then they came out with the nasal preparation, can alleviate suicidal ideation in as early as in 1 hour. So the ketamine trials did pointed out that somebody with chronic suicidal ideations, it may be useful in rapidly elevating suicidal thoughts and as quickly as 1 hour, However, when you use ketamine or esketamine, you have to take into multiple other issues into consideration, such as a previous history of substance abuse. Patient needs to be monitored. The vital needs to be taken. Moreover, selection of patients. We also should select patients who are acutely suicidal on long-term ketamine therapy. I haven't seen great results using ketamine for long-term treatment for just treating major depressive disorders, but it has a lot of value with somebody with active suicidal thoughts, as I have pointed out previously. The other emerging data that is coming along is buprenorphine. The drug like buprenorphine is very useful for someone with severe suicidal ideations. And that is more from my clinical experience using it as an augmenter. But there are also clinical trials regarding buprenorphine that reveals that a max dose of 1.8 milligram a day, which is a very low dose when you use, improves depressive symptoms, and it can also alleviate suicidal ideation. We here at Siyan Clinical, we have an MAT program for opiate dependence. We have about 122 patients who are on various treatments, including Suboxone or buprenorphine, and we have had a good results in also improving their depressive symptoms along with others, in addition to also having some great result with the psychosocial functions for that opiate addiction. Like I said before, the research is that, but it's lacking because one issue with the validity of research studies and clinical trial is the area is that the suicide occurrences are rare in clinical trial settings. The most patients who are recruited have either mild or suicidal thoughts, so we don't have a lot of clarity about what it looks like if we indeed recruit somebody with severe suicidal patients in a clinical trial. When you look at suicide assessment, suicide attempt by highly lethal methods, patient express is a red flag. That is something that one should look into seriously. If somebody has tried to have attempt done through hanging or a firearm, then the highly lethal method points out that they're more likely to die if they use it next time. Patients who express disappointments in failed suicide attempt. When you hear that, that is a red flag. When somebody tries to kill themselves and they come to your office and say, I am disappointed because I was not successful, that means they are at high risk for suicide next time. Inability to discuss any safety plans. They can't discuss any safety plan, how they can be safe. That's a red flag. Inability to refuse or discuss suicide attempts. That's a red flag. Lack of compliance with the treatment. Somebody try to help them. They don't show up for the appointments. They're lost in follow-ups. They're more likely to be successful in their attempt next time they try to do. Severe hopelessness. So when you evaluate suicide, please look into hopelessness as a symptoms. If somebody is hopeless and they have this pervasive communication around their suicidality, that is a red flag. And then agitation and impulsivity is another aspect. And this is more common with our borderline patient populations who are very emotionally volatile, impulsive, and we should look at those patients more carefully. And with that, I would conclude my presentation. We'll all take questions after all presenter speaks them. And I would like to invite now Aubrey, our project director for ERSP. She has come on board and has done an excellent job instituting this program through our grant, and we have done some good work. We have recruited about 100 plus patients into our program, and she would be our next speaker. Welcome, Aubrey. Okay, thank you.
Thank you so much, Dr. Shah. I always learn a little bit of something from you every time that you do one of these, so thank you. Right, so thank you so much again for everyone who's joining us. If you joined late, make sure that you sign in the chat box so you can get your 2 CME or CE credits. We need your email and we need your credentials and your license, so please do that. So to understand how to assess for suicide, we really have to understand the scope of the problem. The problem is on a national level and a local level. So, and as Dr. Shah mentioned in his data earlier, suicide is the 10th leading cause of death in the United States. I reiterate that information only because as healthcare professionals, we really need to understand that this is an epidemic and could be continuously improving on our assessment and treatment methods to improve suicide. So according to the CDC, suicide is impacting people at younger ages and higher rates now. It was the second leading cause of death with ages between 10 and 34. And since 1999, suicide rates have increased by 25%. In 2019, there were more than twice as many suicides as there were homicides. And this data tells me that more and more people are in deep emotional pain and more people are acting in versus acting out. So here you can see suicide rates by age on a national and a local level. National's on the left, United States, and then on the right, you see Sonoma County. Earlier this year, about halfway through our suicide prevention grant, and after meeting our enrollment rate, we wanted to take a look at all the progress that we made. So we got curious about whether or not we were targeting our most at-risk population. So we collected suicide data from the Sonoma County Sheriff's Department and created an evaluation. The graph on the right shows our Project Lifeline clients in orange and Sonoma County residents in blue. Project Lifeline clients who were most at risk for suicide were disproportionately younger in age, between 26 to 34, while Sonoma County's age range for those that died by suicide is between 45 and 54. So if we look to the left graph, we see that nationally, the demographic with the highest rate of those who died by suicide is males who are 75 and older. I wish I could say that, like, oh, we focus on the specific age, we can eliminate suicide, but that is unfortunately not the case. We can conclude from this information that suicide does not discriminate. It impacts everyone in some degree or another. So our suicide assessments need to be thorough, they need to be direct, they need to be compassionate. And in all settings now, you know, it's not just mental health, it's healthcare, it's crisis centers, it's everywhere. So assessing a person's risk factors can help inform us about their level of suicide risk or their level of risk for suicide. Our program uses the Columbia Suicide Severity Rating Scale, which I'm sure many of the healthcare providers are familiar with. And we also assess for protective factors. Harry is going to go over that a little bit later, more in depth, but I just wanted to brush over it now so you know that that's the assessment we use. Most of us have been trained to ask if the person has thoughts of suicide, and if they do, we ask if they have a plan. And then we ask about means, and we ask about method, and do they have any intention? But since suicide is not a yes or no question or answer, we want to really talk about these in-depth assessments. So suicide is associated with several risk factors and protective factors. And like other human behaviors, it has no single determining cause. Instead, suicide occurs in response to multiple biological, psychological, interpersonal, environmental, and societal influences. And that's a useful framework for us for viewing and understanding suicide risk, that we're meeting with a whole person and we need to understand all of those aspects when assessing. So risk and protective factors for suicide exist at each of those levels. So things that we would want to assess for is, do they have a history of depression, a history of mental illness? Do they have hopelessness, substance abuse, a previous suicide attempt, which makes their chances of dying by suicide or completing suicide much higher? Are they a victim of domestic violence and even perpetration? So, and then on a relationship level, do they have a high conflict or violence that's continuous, like I mentioned with the DV cycle? Do they feel isolated? Do they have a lack of social support? And is there in the family someone that's died by suicide or close friends? More recently, there's been this phenomenon called suicide contagion, with more suicides being talked about in the news. So on a societal level, availability of lethal means of suicide, you know, that is probably one of the largest risks, and I'll get to that in a little bit. Other factors are socioeconomic, gender, sexual orientation. So geography, we're really looking at the whole picture, like I said. So, and just as assessing for the risk factors is important so we can determine level of risk, we really also, we want to assess for the protective factors. Suicide is so complex. So someone might have a part of them that wants to die and another part of them that wants to live. And both of those can exist at the same time. And we want to be able to invite both of those in the room. When I'm assessing someone for suicide, I'm holding the space for this complexity with the human in front of me. I'm seeing them as the whole picture, and it's not a yes or no question. You know, it's really, it's complex and there's lots of nuance. And so it's going to take time. So sitting with them for an hour, sometimes even more, is really important. So when I take a look at the factors here on the screen, I would like to invite you to see if you notice a theme and type it in the chat box. I'm curious to see what you all think. I certainly noticed a theme. And Helen, I'm curious if anyone's typing in the chat box, they see themes with these factors. Give me just a sec before I tell you what I think the theme is. Okay, well, support. Yeah, connection. Support, connection, resiliency. I agree. And connection is what stood out to me. While deep breathing, walking, and reading can be very helpful distractions in the short term, they're not solving the long-term problem. So when I'm assessing someone, I want to know who and what they're connected to in the long term. Do they feel a part of their community and a sense of belonging and friendships? Do they feel connected to their mental health and physical health providers? One of my favorite trauma researchers and the founder of what is right now one of the most effective developmental trauma models says that connection is our deepest desire and our greatest fear. And that just really lands. I think, when we think of someone who's isolated, it can be really scary to reach out and to get support. We're afraid of being seen. So here we have another comparison on a national and a local level. These numbers are a little bit more clear for us here. So we can see that on the national and local level, guns are the most used method used for those who died by suicide. And there's some variation in the categories. You can see in Sonoma County that there's more hanging, whereas on the national level, there's suffocation. And I just, I think that it's important to notice because I think by region, we might see more pattern. And so, take note of the graph on the right, and we'll email this out afterwards so you have this information. The County of Sonoma will provide it to you if you were to ask too. So lethal means includes any method of harm that results in death. Assessing for lethal means should happen before the person is in crisis so that counseling and planning for safety can take place. And ideally, this is on the first visit with the client. After we've asked the person using some direct, compassionate language, when was the last time you thought about killing yourself? That's how direct it needs to be. I think when people sense that we're nervous, they start to feel nervous. They don't feel like it's a safe space to be able to talk about it. Then, we want to know, have you thought about how you would kill yourself? And if the person does mention the method that they would use, then we ask, have you thought about other ways? Really inviting them to tell us every way that they've thought about it, because most of the time, it might be driving their car off a cliff or something like that, but there might be another lethal mean. They might be stockpiling prescription medications, and we need to know about all of that so we can help them plan. So it's our responsibility to not only ask if someone is thinking about suicide and assessing for the method, but to ask every single person, if they have access to a firearm, even if they said they thought about killing themselves by hanging. We live in Sonoma County, surrounded by rural area. Many people enjoy hunting around here. There's a couple of gun clubs that I know about. So we have a lot of access. We need to ask everybody, what kind of gun do you have? Is it a long gun or handgun? In doing research for this presentation, I've learned a lot about guns, and gun safety. So I think the more familiar we are, the more we're going to be able to support our clients with that. And there is, if you Google online gun safety, there's a ton of information that comes up as a provider for support with that. I can always email out that information to you. Just type in the chat box if you're interested. We also want to ask, is the gun semi-automatic? Is it loaded? Do they know how to operate the gun? Is the gun locked and stored in a gun safe or a vault, most importantly? Many people store their guns away from home while they are going through a rough period. It's like keeping the keys from a driver who's been drinking. Temporary offsite storage is the safest approach. And that's where we can help the client coordinate, and it might take a little bit more effort, but we want to be assertive. We want to say, can we get a release of information, or can we help you call your mom or your dad or your friend right now? I think coming up with a plan in the office is great, and I've had clients that do fall through, but I just think it's more assurance if we can really get their friend on board or that support person on board while they're with us. Other options for self-storage or for storage offsite is a self-storage rental unit. At some places, they'll allow you to store guns unloaded. A gun shop or a shooting range, if you're a member, they'll sometimes allow you to store them there for free too. You just have to ask. And pawn shops, for a small loan, you can leave your guns there. And that is in with most states, but I would suggest calling before just going with your gun. So yeah, and I think, you can also store at the police station, but you want to check with all of these places. If you're going to store them there, check their policies online or call to double check. So if none of those options are possible, a locked gun is safer than an unlocked gun, and an unloaded gun is safer than a loaded gun. So, we want to make sure that our clients are locking them up and they have access to safes and making sure there's no ammunition. And this is really important, I think, when we're talking about gun safety and counseling with our clients. We do not want them to hide the gun, especially if it's not locked, or family members and especially children and teens often find them. And, we've all heard those stories. They're terrible. If they do, then there's some tragedy that can happen. And we want to make sure that not only the person at risk is safe, but the family is safe as well. So when counseling on prescription medications, we want to encourage all of our clients to remove the unneeded and expired medications from their home. Sonoma County has a safe medication disposal, and it usually happens quarterly. And again, if you have questions about that, you can email me, or you can call Poison Control Center at 1-800-222-1222. And they'll be able to give you information about how to dispose of excess medications. So for necessary medications, we want to keep only non-lethal quantities on hand and ask a pharmacist for advice. Lock up abuse-prone drugs such as painkillers, anxiety pills, amphetamines, sedatives, and tranquilizers. And that's, again, that's lethal means as well. So now I'd like to introduce our Project Lifeline psychotherapist, Carrie Knine. Carrie is a licensed marriage and family therapist with over 5 years of experience in suicide intervention and prevention. She brings training and expertise gained by working in various crisis support roles. She has worked with the mobile support team and the crisis stabilization unit. She uses positive psychology as one of her main approaches to focus on clients' strengths and values. And so without further ado, here is Carrie. Thank you so much.
Hi, everybody. Just want to take a minute to thank the people behind the scenes that are helping make this presentation possible. Thank you, Argo and Helen, for your help here. Makes everything go just a little smoother. So let's see, it's my thing. Oh, there it goes. Yeah, so one of the things that I wanted to talk about that I got interested in when I was working in these various roles as part of my internship prior to licensing is this idea that, and I'm sure you guys are all aware that to some extent we have these silos of care. And the silos of care happen because we're not allowed as providers to share information between institutions. And so I wanted to just sort of talk not so much about how it really doesn't serve the patient or put the patient at the center of care, but how we as providers sort of turn that around. The other thing I want to talk a little bit about is setting the expectations with the supporters or the family members of the people who are going through a suicidal crisis. A lot of times people have the idea that they're going to get a bunch of information from the hospitals. They're going to know exactly what's happening and when. And a lot of times it's the exact opposite of that. And so in the acute phase, like if somebody is feeling imminently suicidal, like in the next hour, next 6 hours, half a day, you have a number of options in our county to get them help. And a lot of that changed with COVID-19. You used to be able to take people to, say, Aurora Hospital or to Crisis Stabilization Unit direct and keep them safe, like overnight or until they could be redirected to longer term facilities. But with COVID-19 and the requirement for a test prior to going to either of those places, now the single sort of entree to this kind of care is through the emergency rooms. And so through Sutter Kaiser Memorial Hospital, and after they're tested, then usually the psych liaisons are the ones that redirect patients' care. So this initial sort of acute phase can last from 72 hours if they've been put on an involuntary hold to 2 or 3 weeks if it's somebody's first psychotic break, or they can't be stabilized on medication because of some additional biological factor like Dr. Shaw mentioned earlier. So there's a number of things that influence our ability to stabilize a patient, and it's not just all about psych meds. When patients go into the hospital, they're either, sometimes they're unwilling or unable to give the hospital sort of a 360 view of what's been going on with their mental health. And unless they sign a release allowing family members to get information about them, they also may not benefit from gathering collateral information. Collateral information is very important when you're working with somebody sort of an initial psychotic breaks where there isn't a lot of information in an electronic health record. They sort of have, I don't know, like a bystander sort of dispassionate view of what's going on with their beloved. If you feel like somebody you love is in a crisis and they're unwilling to go to the hospital, they're afraid of what's going to happen next. If you feel like suicide is imminent, some people do call crisis stabilization unit. They're staffed 24/7 with very knowledgeable, very helpful people, and they can let you know whether it's appropriate to bring them into the hospital. I have known some parents who are worried about their kids' well-being, and you can also call in a welfare check with the sheriff or police department. You can ask them, if it's Monday through Friday, sort of between the hours of 9 and 7, you can ask that the police bring out the mobile support team. Unfortunately, in our county right now, the only way to access the mobile support team is if you ask the police to bring it. You can't call the mobile support team yourself and have them coming out. I did read in the Press Democrat that there's grant funding available in Sonoma County now to set up a team like the mobile support team to respond to crisis that you don't have to access through the police, because I know a lot of parents are worried about their kids when they're dysregulated, about being putting them in harm's way, I guess I should say. I know other counties in the state of California have these mobile support teams. It's very organized, very tier driven, depending on the level of acuity, and they do send teams out that don't have police backup. The challenge in our county is how do you then transport the person to the hospital? And the only people who are able to transport right now are the police. So it's a gotcha, a little bit of a gotcha that we're working on. The post-acute phase, like if somebody's having a first psychotic break or if they're returning to their medication, it's super important that they get into a post-hospital program, a PHP or an IOP. Somebody may have been given medication while they were hospitalized, but to get a refill on that medication, they have to make contact with a psychiatrist in the community. And psychiatrists in our community are really limited. There's a handful of people who provide this kind of care, an even smaller number of people who do it for adolescents and children. And so fortunately at Siyan, we manage, a wide spectrum of populations, including the adolescents. But the PHP and the IOP is beneficial because it gives us eyes on the patient after they're discharged from the hospital. And this does two things. It's like, okay, one, how are the medications treating them? Or is it stabilizing them? Do they need to be tweaked a little bit? And two, it gives the family who's supporting this person a bit of a respite. So you can imagine if somebody's come out of the hospital where they've either attempted suicide or threatened and had means and a plan, they're hyper vigilant. They're sort of taking the doors off bedrooms. They're got a 24-hour watch, and that can be exhausting. So another benefit of the PHP and the IOP, besides having a psychiatrist eyes on and having support staff who can sort of track symptoms over days, is it's the respite for the family. And so I strongly encourage anybody who has somebody going through this kind of crisis to engage in those programs. We have some good ones in our county. This phase can last, from the time of discharge from the hospital, can last usually PHP is like 6 to 8 weeks. And then they go to IOP, which could be another 4 weeks. And so getting somebody the right mix of medication to stabilize them, their depression and their suicidal ideation can take some time. And so you need that support to go the long haul. And you need that time often to get the appointments with a psychiatrist in the community so your medications can be refilled so that you can get connected with a therapist. It can take months to get into care like this. And so I strongly suggest the PHP or the IOP for that reason. And then the patient-centered care, I think we talk a lot about that, about putting the patient in the middle and then having all of us who are providers in the community share information, like getting the release of information so I can get records from the hospital or so that we can get sort of diagnosis, because it's a long road, this depression fight, this suicide fight. It's not a one and done. And so every interaction with a care provider provides a little bit more information that helps us really get a full view, maybe even before the patient themselves is aware about how best to help them. So generally when people are discharged from the hospital, they have a safety plan. And sometimes the safety plans are just put onto a desk and put under papers and people sort of forget it's there. But that's usually the first thing that we here pull out and want people to pay attention to, triggers and warning signs, because those are the things that we help educate the family on, like here's what helps and here's what definitely doesn't help. So yeah, and then we build these collaborative plans with our patients around DBT for emotional regulation, CBT for those cognitive distortions, and then I spin in positive psychology because I feel like resilience and hope have to come into the mix, and medications don't often layer that into a patient's psyche. The other thing I do sort of is like do this little, I don't know if you can see that, it's like a bullseye where the patient is in the middle. And it's a visual way of helping the patients understand who is available to support you. Who's here in your city, who's here in the state, and who actually, like, are your parents on the East Coast? Where is your main support team? If they're not here in our city, if they can't be reached within 30 minutes, a lot of times that's the place we need to start, back to what Aubrey was saying about connection. Okay. So we talked a little bit about the CSSRS, and like the GAD-7 or the PHQ-9, which are evidence-based tools around depression and anxiety, the CSSRS is another one of those tools that gives us an objective score about how severe someone's suicidal thinking is. I feel like it's a really good educational tool for people as well. When somebody is severely depressed, suicidal thinking is just part of what happens to your brain chemistry when you're severely depressed. And so I want to normalize that for them because I want them to be able to talk about it like they talk about last night's dinner or their friend from last week. It's just got to be a part of our conversation now that there's been this serious crisis event. And I want them to have the vocabulary to talk to me about it. And so when I sit down to talk to somebody about their suicidal thinking, it's not any one data point, but rather, as Dr. Shaw said earlier in this presentation, it's a collection of things. It's the biological factors like pain or chronic illness. It's, maybe it's economic status, something happened, they lost their job, or two people lost their job. It's a whole bunch of things that create this sort of confluence of events. And so when I talk to people about the frequency of their suicidal thoughts, For some people, it comes and goes, or it's triggered by somebody or something in their environment. But for some people, they're around for 8 hours in a day, and that's a problem. So talking to them a little bit about how long are these thoughts sticking around? Are they always with you, or do they just come and go? Are they triggered by work? Are they triggered by interactions with loved ones? And then I talk to them about, like, can you control them? Do you have something you can say, like, all right, I'm going to get through this, you know, another day, it's going to be better. You know, you did this before, you can do it. But a lot of times when people are severely depressed and they're hopeless and they have the plan and the means, they feel like they can't control it. They feel like, in fact, that the thoughts are controlling them. And so that also is a pretty big red flag for me. Deterrence, you know, that can be things like kids, or allegiance to family, or faith, or like Aubrey pointed out, around connection. Like, that's, to me, is the main thing that we need to reinforce for them. That's partly what this is meant to do for people, is sort of just show them, okay, there really is no one in my city who I can look to for support. How do I change that? And on the reasons for ideation, for some people, it is about ending the physical or emotional pain. But I also want to normalize for those patients who talk about wanting to bring attention to the fact that they're suffering, vocabulary for talking about it. And so those are borderline personality, maybe, patients who feel like when they're upset, no one is listening. And so they have to take it to the next level. And so talking about that can destigmatize that for us and for them, and also help sort of point out ways that we can help with emotional regulation. Sometimes when I read that question to patients, you know, is it for attention? They were like, no, it's not for attention. But if you think about it in their hearts, whether it's almost like a little kid who just needs to be picked up and held. Like, are you suffering and no one is listening? And that's kind of how I phrase it for them. Both, I think Dr. Shaw and Aubrey have talked about protective factors. So I don't really need to beat those to death. The ones in here that I'm really, I personally feel like we need as part of our long-term planning is around sense of purpose and self-esteem. And I'll talk about that a little bit more. So the things that I do, because my part of this is the treatment portion. So I also love the evidence-based tools, because it gives me something to use to communicate to their prescriber and my, you know, peers on the therapy staff. But it also helps my patients sort of develop a language around, well, what cognitive behavioral therapy, but what does that mean? And so when we talk about negative core beliefs and the way that they slant a patient's worldview, this next assessment tool sort of helps us speak to that. I found this tool online, and the source there is at the bottom of the slide. You can Google it and pull it down. It's a 100-question self-assessment across 10 domains. And those 10 domains are down there at the bottom. Value, like, do I count? Do I matter for something in this world? Security, control. With security, I found people's security scores dropped during the COVID pandemic. Life suddenly became unpredictable and dangerous. Control, what control do I have over my life, over my mental health? Performance, like, how well do I do at work? How is my critical thinking? Love, am I loved? Am I able to sustain sort of deep connection, or are all my relationships super shallow? Autonomy, when people have low scores on autonomy, a lot of times that speaks to codependence. So they're not willing to speak their minds. They're not willing to make their needs known because they've never learned how to do it. Justice usually speaks to, it's not fair. You know, I don't get a fair break. That sometimes can be an indication. That's sort of one of the symptoms for borderline personality traits. So that's something I use to open up a discussion about that. Belonging, I feel like of all of those things that we talk about, belonging is like number one. I 100% agree with Aubrey there. If people don't have a sense of connection and belonging, either within their broader community, but especially within their family and peer group, it's really hard to convince them that it's important to stick around here on this earth. And so it can also be the hardest one the negative cognition can be one of the hardest ones to mend. It's definitely one of those ones that if somebody pushes on it, say a friend doesn't return a call for 3 or 4 days, it's very easy to go from 0 to sad or 0 to angry. So these core beliefs are places where people go from 0 to super angry, 0 to sad, mad, angry, scared, and lonely. I throw in lonely in there because lonely also it can be very lethal for people. They feel super isolated. And so there's 100 questions. The low scores correlate to places where people got negative messages as kids that were affirmed over time as adults. And then 0 scores are places where people had negative messages as kids, so they're just as likely to have their triggers tripped by them, but they had reparative experiences, so you can borrow from those to help sort of mend those old wounds. I talk about this as sort of an emotional kryptonite. It's sort of the entree, I feel like, to DBT and emotional regulation. And I often use positive scores from one domain, like borrow from those strengths to heal some of the negative scores in other domains. The other assessment tools that I rely on a lot, like I'm sure you guys all know about Therapist Aid or positivepsychology.com, but there's a ton of tools out there. And I use them a lot because when patients do both, like my new patients all do the core belief inventory and they all do this protective factors because it's a visual representation of where they are in this moment. And so this protective factors, even though they talk about it in the hospital and the part of the discharge plan, people don't really get it until they see it. And so this assessment tool is really great because it dovetails into our treatment planning. So coping skills relates to DBT, healthy thinking corresponds to CBT or a need for CBT. Physical health, if that's a contributing factor, we learn more about that here. Social supports, and then self-esteem and sense of purpose are correlated in my mind, in my experience. If somebody has a really strong sense of purpose, their self-esteem is also really high. But especially during COVID-19, when students were coming back and living home with their parents, or when people were losing jobs, or maybe kids moved out of the house, people were in this period of flux and transition and their identities were disturbed. And so they lost the sense of purpose that they had before. Or if they're 20 somethings, maybe they haven't really fully developed it yet. And so that part of this protective factors, I feel like is the longer term, like in the year mark or the 9-month mark, after we've stabilized them on medications, after we've got them past the crisis, after we bolster their social supports, after we sort of optimize their health, then we start looking longer term about how do we keep them from, how do we raise their happiness set point? How do we keep them from dipping down back to that dark place again? So this just speaks a little bit to my thoughts about resilience and optimism and their ability sort of longer term to prevent risk of suicide. And so I like this author. I don't know if you guys have seen his book, Viktor Frankl. Dr. Frankl survived World War II in the concentration camps, and he did so because he had a higher sort of purpose and a faith and affinity for God and connection with community, but also the belief that he had to survive to be there for his family on the other side. And so he said that our primary motivator is not pleasure, but it's this discovery and pursuit of what we find personally meaningful. And so I'm super excited about that part of it. Of course, in hospitals, that's not where their focus is because they're trying to keep you from harming yourself. They're trying to keep you stable on medications. But once you get beyond that, and the way you do that, again, this is sort of from a treatment perspective, is daily gratitude practices. So sometimes gratitude is hard to approximate when you're depressed. And so I talk to people about 3 good things. So writing down, journaling every day, 3 good things that happen. And it can be as banal as, oh, the dog made me smile today, or I had a good dinner with family. But I really try to get them to see bigger picture. I have financial and residential stability. I'm close to my partner and loved one. I have a job, that is keeping the lights on. Like, there are many blessings, but when we're depressed, we don't see them. Some people are visual, so I have them take images of the things that make them smile. And then the thing about positive psychology is they want you to savor that, right? Like you do like a hard candy. Keep that thought in your mind. Let the, dopamine, let those positive chemicals roll around in your brain, so that you retrain your brain, from neuropsychology to see that there is positive things, to attune your body to those positive feelings when they've been absent from your life for so long. There's a lot out there right now, specifically, especially with regards to like the combination of mindfulness and positive psychology, and mindfulness and DBT, mindfulness and Buddhism. People may not be religious, right? But most people can relate to that sense of being connected to something larger than themselves. The other thing that I'm kind of excited about that I use more with my younger patients, not necessarily with people who are technology adverse, is there's a lot out there now on mobile apps that help address like mood tracking devices, so you can see how your moods go from one day to the next. I find this is really important for people who are trying new medications, and they may attribute, well, I can't sleep, or I sleep too much, and they may blame it on the medication, but it may have nothing to do with the medication. So having them track their symptoms sort of objectively helps give their prescriber sort of a clearer view about what's going on. But there's apps that track the mood. They can do interventions for depression and anxious thinking. They have apps for a suicidal ideation, sort of a hot button you can push. My 3 is one that helps you call people who can, whisper some sweet honey in your ear when you're feeling depressed. So there's a number of really great apps out there. Calm and Headspace are both great ones for mindfulness, trains your brain for mindfulness, because that's kind of hard when you first are coming onto medications to keep your mind clear. So there's a lot out there, and there's a lot being studied out there. So UC Berkeley here in the Bay Area, University of Pennsylvania, positive psychology. A lot of universities are spending time in creating podcasts that are easily accessible for end users about the science of happiness. And so once people have sort of moved beyond the acute and the post-acute, and they're stabilized on meds and they're building connections with people, then I start asking them to listen to either TED Talks or podcasts that help sort of as part of psychoeducation, so they become more aware of other ways of thinking. I had a patient once in the hospital who told me he felt like CBT and DBT focused on what's going wrong, on the past. And while I think it's important so that we can track sort of patterns of behavior, it also sort of highlighted for me the need to sort of figure out how to help them see what's going right. And that's super hard, especially post-acute phase. So it was a lot of information. It's my pleasure to introduce Karina Pena. She is our case manager, but also assistant project manager. She has more than a decade of experience working with at-risk children and families. And her presentation is going to be awesome. So take it away.
Alrighty. Good afternoon, everyone. Now that we've moved through Dr. Shaw's view on medication and Aubrey's introduction to Project Lifeline and facts about suicide and methods, and Carrie's assessment tool and emotional regulation tracking. I'm going to move into is case management and the role of case management in mental health. So I'll go ahead and start. So case management and suicide prevention, again, Aubrey had mentioned that suicide is one of the 10 leading causes of death in the United States and taking the lives of more than 44,000 Americans every year. So with increasing suicide rates, suicide prevention needs to be a top priority in healthcare. And while prevention measures, yes, they have increased, there are still many areas in which healthcare professionals can improve care for mental health. So according to some of the studies and the issue in medical care, 38% of people who attempt suicide make a healthcare visit within 1 week before their attempt. 64% make a visit within 1 month before their attempt. And making suicide prevention a top priority in assessing mental health at every opportunity, this could lead to lower suicide rates and improve care for mental health. One way to prioritize mental health care is to assign case managers like myself to intervene, especially with chronic patients who may be more likely to suffer from depression or suicidal thoughts. We have the ability to be able to catch people when they're coming into those visits. And so it's an important role. The role of case management with patients, number one is we as case managers are regularly seen as an extension of other care professionals and are trusted just by default. We offer advice, tips, assistance, help, support, guidance. But more than that, when we're doing that with compassion and meeting patients where they're at, they're able to build that trust that allows patients to be more open with case managers. And case managers enhance coordination of care. We do skill building, navigating resources and systems, and help patients meet essential needs and assist in improving the health of the patient. So there are different ways that they can build relationships and trust with patients. So to assess for depressive and suicidal thoughts, it's really important for us as case managers to be able to just sit back and think, what is really going on with this patient, and do I need to get some assistance from my team? So how case managers can help? Number one is case managers help patients secure essential resources. So to better function in therapy, patients need to have essential needs such as food, shelter, medical care in place. Without that, it's very hard for somebody to function in therapy. So by providing skill building opportunities that offer psychotherapy at a surface level, case managers can forget emotional support and prepare a patient that may be kind of on the fence for more of an in-depth therapy with a provider. So case managers sort of normalize that psychiatric treatment and move patients on into the meat of the work, which is working with a psychotherapist or a psychiatrist. Case managers build relationships of trust. And this is very important because even though case managers may not see it, we do hold a position of trust, and it's a pretty powerful position. If a patient has trust in a case manager, the case manager can navigate the patient with suicidal ideations and intention to allow the appropriate psychiatric assistance to happen. So we sort of bridge those gaps of communication, and we can always follow up with additional support, again, as somebody that the patient will trust. Lower cost. The Suicide Prevention Center lists the average cost of one suicide at more than $1.3 million. So every $1 spent on psychotherapeutic interventions and interventions that strengthen linkages among different care providers saved $2.50 in the cost of suicides. The goal of the case manager is to get more people linked to mental health treatment, which can save their life in the end, improve mental health, and ultimately reduce costs. So while there is a lot of work to be done in prioritizing mental health care and suicide prevention, assigning a case manager to make this one of their main concerns is a step in the right direction, which is why I'm so happy to be and privileged to be part of Project Lifeline. The role of parenting in suicide prevention. As a case manager for Project Lifeline, I've had the opportunity to also offer parenting resources and a parenting class. At Siyan, the case management role offers patients a combination of emotional support via skill building classes and parenting assistance geared towards suicide prevention. Now, this was built on a need. I think Aubrey had mentioned that the age group that we were serving were in between their mid-20s to late 30s, most of our Project Lifeline patients. And so, again, a lot of our patients did have young children. So they are going through mental health issues themselves while trying to raise a young family. So a parenting support group did come in handy, and it's been pretty popular. We offer an ongoing 10-week parenting course for patients that cannot make the class time or day, and one-on-one parenting sessions. So by providing a preventative class, patients learn alternative ways of reacting, processing, and connecting to their children. The goal is for patients and children to experience more healthy connections and a way of coping with stress especially during COVID and during the isolation. And the changes and ultimately reduce the risk for suicide for both the patients and their offspring. Suicide in teens in recent years, a little bit more about suicide in teens. I know Dr. Shaw had mentioned, so I'll breeze through this, but suicide in teens in recent years is estimated at 16% of California 9th and 11th graders, and 70% of non-traditional students have seriously considered attempting suicide in the previous year. So at least 20% of girls in each grade level seriously considered suicide, compared with less than 13% of boys. Students with low levels of school connectedness were much more likely to have serious suicidal thoughts, that's about 32%, than their peers with medium, 19%, or high, 9% connectedness. And again, I believe Dr. Shaw talked about this connectedness, and the proportion of gay, lesbian, bisexual youth or youth that are not yet identified seriously considered attempting suicide was 44%. So it was a lot higher than students that were, heterosexual. Positive parenting, learning the risks. So important to learn the risks of what happens with your kids. Suicide isn't, in the news, it's popular entertainment now. There are shows. I put up here the show 13 Reasons Why, which many teenagers know about this show, but you can play a role in building up your child's mental health simply by becoming aware of the risk factors and warning signs that can lead to suicide. And this is what we try to work with the patients on, something like making yourself available to your child, knowing how to practice having a caring conversation, and being able to be aware that help is available and is key. What we know today is that for more adolescents, suicidal thoughts or attempt to suicide, they survive it. So there's more people that survive than those who die by suicide. However, there are still those attempts. Results from the 2019 Youth Behavioral Risk Factor Surveillance System show that in the past year, 18.8% of the high school students seriously considered attempting suicide, and 8.9% actually attempted suicide. So what can I do to protect my child from suicide? What can you do? What can our patients and our clients do? Well, we can teach and model healthy habits for mental health, just as you would with physical health. We take care of our bodies by working out, by eating healthy. Same thing goes with our kids and showing them those healthy habits of mental health. So taking care of your own mental health and seeking therapy when warranted is one way to model healthy practices. If your child sees you approaching your own challenges and learning from your own mistakes in an open way, they will understand that it's okay to struggle and learn from the mistakes. They may develop flexibility and compassion for their own missteps. They will also understand that life is messy and challenging, and everyone has differences at different times, and they'll know how to meet those challenges. They can also check in with you regularly, or you can check in with your child regularly beyond just the day-to-day tasks such as homework. You can learn how to invite a deeper conversation through further guidance, and it's listed on this page. If your child has a history of depression, anxiety, suicidal thoughts, self-harm, substance use, you should monitor them more closely and consider involving a professional either at key times or for longer term for more chronic conditions. There is always, again, support in the community and people like myself, case managers, that you can go to for guidance and linkages into the community. Knowing the signs, it's important to know the signs, find the words, and reach out. If there's only these 3 things that you could remember about connecting with your children, your teens, know the signs, find the words, reach out. Talking to your child about suicide. Don't be afraid to have a conversation with your child about mental health and suicide. Simply ask them, you know, what's going on? Are you okay? You listen intently without judgment. Ask open-ended questions that cannot be answered with a simply yes or no. Resist the urge to offer quick fixes or solutions to their challenges, because again, that tends to shut them down further. Validate and support their feelings. Again, listening without judgment. We want to follow their cues. Say things like, tell me more about that. I'd love to understand more. And what's that like for you? Now, should I use the same approach for different age groups? Ages 8 to 12 or teens 13 to 17. The approach is very similar for tweens and teens, but with changes in language based on their level of sophistication and self-awareness. Of course, if it's a younger child, you want to use a different language approach and reach out to the professionals if that's what you wish to do so. Use language that makes sense to your child, given their age, development, and what you know and how they think about things. For a young child, you can ask about physical symptoms like stomach aches, changes in feelings, like getting upset or angry more lately. For older children or kids who have demonstrated they are aware of their own thoughts and feelings, you want to ask about their perceptions, their symptoms, sleep problems, mood changes, feelings of hopelessness, or feeling trapped or overwhelmed. These are all things that a case manager can assess for. What if they don't want to talk? This is often the problem with many young adults, but it's important that you don't have to struggle in silence, and remind your child that whenever you want to talk, I'm here to listen and support you. Remind your child that I won't judge and I'll never stop supporting you no matter what challenges you face. And remind your child that you're there for them. The likelihood is that your child will open up when you least expect it. So sitting side by side rather than face to face in the car or engaged in some other activity together, they will eventually open up. It's just those constant reminders of you don't have to struggle in silence. You also want to have a place where you ask directly. I have a hard time asking for help. I think many of us have a hard time asking for help, but it's important to ask directly. If your child is talking about any level of distress, do not hesitate to ask them whether they're feeling changes in their mood, their level of stress, or having suicidal thoughts. Asking your child directly about suicide will not increase their risk or plant the idea. It will create an opportunity to offer support and let them know you care enough to have the conversation. Also, finding help together. Anything is possible when you have the right people there to support you. So it's really important to find help together. You can say things like, can you say more about that? I'm here for you no matter what. There's no problem too big that we as a family can't get. I'm going to keep supporting you, and I will also make sure to get the help you need to feel yourself again. You want to talk to your child about how to seek help. If you fear they may be at risk, get professional help right away. Let them know you'll be there for them no matter what, non-judgmentally, and that your love is unconditional, and that you'll help them get that support they need so that they can become themselves again during a challenging time. And here are lastly, some resources. Calling 911 is best for a situation when self-harm is occurring or is about to occur. But we also have our crisis stabilization unit, which is open 24/7, a North Bay Suicide Prevention Hotline, Sonoma County Behavioral Health Access Line, Suicide Prevention Lifeline, which I think Aubrey had given 273, TALK, Suicide Prevention Information for SoCo Emergency, and CHOPS Teen Center, all good resources to look into for anything that may be happening with your child. And now we're going to move on to questions.
Okay, so we have about 20 minutes or take for questions. So if you have a question, go ahead and type it in the chat box and we can field it to whoever it's most appropriate. Also, if you didn't get a chance at the beginning, please type your name, your credentials, your email address, and your license number in the chat box so we can make sure that you get the CME or CE credits. And those are free to you from Siyan. So. Any comments? What did you like most about the presentation? Are you awake? Do you have coffee or tea?
No questions? Can you talk a little about personality disorders and suicidality? Is that from Kevin? Kevin Galvez is asking.
Personality disorders and suicidality. What specifically would you want to know about the relationship between the two?
The update information.
Let the person unmute themselves.
Oh,
So they can.
good idea. Yeah, so if you want to unmute yourself to elaborate a little bit more on that question and we can talk through it together.
My sound might not be great. Can you hear me okay? Can you hear me okay? I'm sorry. Can you hear me? Yeah, my sound isn't great. Can you hear me at all? Can you hear me? Okay, just so maybe just want to know more about borderline personality disorder, maybe treatment,
Volume issue, maybe.
DBT and other treatments specifically for BP.
When you unmuted yourself earlier, I couldn't hear you either. I don't know. Maybe it's the connection.
Okay.
Okay. Well, Kevin, if you aren't able to unmute, then maybe you could just ask the question in the chat box, elaborate a little bit more on what you mean by that. Oh. It's me?
When he was unmuted, we could hear him just fine, and then he seemed to be muted again. And
Wonder if it's because I'm
unmuted.
Yeah. No.
Sorry, everyone. Can't hear you, but please type in the chat box if you have a question.
BPD and treatments other than DBT. That's kind of.
Yeah, so borderline personality disorder, and is there any other treatments besides DBT? Yeah, there is. So, and Dr. Shaw can speak a little bit more to it, but I know for myself, I'm a psychotherapist as well as a project director. I use neuroaffective relational model, and it's been extremely effective. I think it really helps address like childhood trauma, which, you know, that's the origination of borderline personality disorder. And it focuses on the relationship to self and the relationship to others while highlighting agency. And so I would encourage you, if you're, if you provide direct service, to look up this neuroaffective relational model. And I've seen clients start to really gain more of an internal locus of control and reduce suicidality. And then Dr. Shah, did you want to speak to that? Okay.
So this is a good question, and I think we just hit the DBT is the core treatment, and thank you, Aubrey, for elaborating. When you look at biological point of view for someone with impulsivity, someone with mood swings and a personality disorder, I think there are two things we always need to assess is the comorbidity. A lot of people with personality disorder, especially the borderline type or histrionic type, they have a comorbid depression. So when it comes to biological treatment, you can always treat the depression along with that. Now, there are some trials which have shown some benefits of using divalproex sodium and oxcarbamazepine for someone with severe mood swings related to impulsive act. There has been 2 trials that have shown to be positive results when it comes to self-injurious or cutting behavior. And then we have used gabapentin and divalproex sodium in those cases. The results are hit and miss. It works for some patients, it doesn't work for others, but some biological intervention may also be helpful for someone with parasuicidal behavior and having self-injurious behavior. So that's just my biological perspective. But once again, like you pointed, Kevin, I think the DBT therapy is a core first line of treatment with somebody with personality disorder and self-mutilating behavior. Thank you.
Okay. Hopefully that answered your question. We have a couple different perspectives there, biological and also developmental. Any other questions? And again, if I'll just last reminder, if you didn't put your name in the chat box, name, email address, most importantly, because that's where I'm going to send the evaluation for this presentation. And I have to get a completed evaluation in order for you to get the CME and CE credits. So make sure to put your email address in there.
The prevalence of mental health disorders has increased during the pandemic, with more people reporting symptoms of anxiety, depression, and suicidal thoughts. What role does nutrition and lifestyle play in optimizing mental health and managing stress?
You want to take that one too? You're going to leave me high and dry. I can't speak to nutrition. I would say that's probably out of my scope of practice, but Dr. Shah, I'm going to throw it back to him. He's going to answer that question.
So let's look at nutrition from 2 points of view. One is obviously if you look at the antioxidant aspects that the nutrition brings, that removes the free radicals. So, obviously when you use green vegetables, fruits, those leafy elements in your diet, it has an antioxidant values, and that improves the mood, Now, when it comes to some alternative treatment, when it comes to managing somebody's mood, there is some data which suggests vitamin D3, omega-3 fatty acid or fish oil, when you use in conjunction, can improve some mood-related aspects. Exercise has a pivotal role in managing depression and anxiety, as you all may be aware. And there are trials that have shown it to be very helpful. If you do aerobic exercise, 30 minutes, 5 days a week, it does improve mood. So there are data around that. Yoga and meditation has also had a significant evidence-based implications in when you try to treat someone with severe depression or anxiety, utilizing that. So that is also another one. Now, so that's what we could speak about nutrition and other alternative means that may also be helpful to the patients. One other thing we have been telling our patients that if you are able to walk 10,000 steps a day, it would really help. That is a pivotal thing in maybe getting that inertia going. If you have a cognitive behavioral therapy interventions and somebody is low motivated, if they start working on their steps and get up to 10,000 steps, at least in our observations in treating patients, we have seen some benefits in their overall level of functions. That's all we can speak. Sure.
This is from Hattie. What are your thoughts on morbid ideation? Definition, symptomology? Is it a good risk assessment tool, etc.?
Well, as far as the risk assessment tool, we are familiar and we have used a lot CSSR, and Aubrey speaks in much more length about that tool that we have been using for ERSP grant related work. We also use CSSR when we do clinical research or clinical trial related work. So, and CSSR is a good tool that helps you really take suicidality into perspective, and also sort of, it gives you a score which sort of puts patient into a category of severe at risk, moderate at risk, mild at risk. And for CSSR, it's a free training. There's a clinical tool that is available, and there's another tool for clinicians, and I think there's an online training for that, and it's free. That's all I could speak about the tools that we have used. Aubrey, you want to add anything else to this question?
There's another.
Yeah.
Any use of herbs such as adaptogens?
I couldn't speak about that. I have no experience or knowledge about that. I have I've heard some role about using Ayurvedic preparation like ashwagandha for treating someone's mood. And there are some providers, colleagues who have used it with some positive results. But I'm sorry, I haven't heard about the one that you are talking about. Okay, thank you. It looks like nobody has additional question at this time, so we will conclude our presentation. I want to thank all participants for their presence and lovely questions. And are there any other logistic requirement for CME credit that we want to let the staff know before we conclude or end?